Good evening. Welcome to day 2 of our Facebook Live Stop the Bleed training event. We are Contingency Consulting, a national public safety training and equipment company with offices on the West Coast and right here in Selma, Texas. My name is Rick Smith and I'm the Chief Consultant. A little background about myself is I'm a retired 27-year police officer with the City of San Antonio, where I spent my last 16 years on special operations, where I managed a tactical medicine program as well as other duties. Prior to becoming a San Antonio police officer, I was a firefighter medic, and then prior to that, I was a United States Marine. So, why are we here? We talked about it on day 1 that May is National Stop the Bleed Month. And if it wasn't for COVID-19 and the social distancing guidelines, we would be out across the country doing these offerings face to face. But unfortunately, due to those social distancing guidelines, we thought it would be best to use Facebook Live as a way to get this training to you in your safe spaces. So we shifted gears and we're here today. As on day 1, we want this to be a very interactive format. We had a lot of great questions on day 1, and we hope to solicit some great questions here on day 2 as well. So if you have a question, just shoot it our way and we'll answer it to the best of our ability. Just like on day 1, Chris is still behind the camera. Say hello, Chris.
Hi, everyone.
I promise you we sent him home after day 1. He just happened to come back for day 2. And also, Melissa, my wife, is going to be assisting us on demos as well, and you'll see her a little later on. So, let's get started and have a quick summary on what we talked about on day 1. So if you remember on day 1, we talked about the 6 principles in stopping the bleed. And we got through about 3.5 of those. So the principles that we talked about was ensuring your own safety, making sure that it's safe enough for you to do these interventions so yourself, you don't become a victim. Very similar to riding on the airplane when those oxygen masks fall down. We need you to put your mask on first before you assist anybody else. So safety is the first step in hemorrhage control. Then 2, we talked about locating and identifying bleeds. So locating, we talked about open pipes, big pipes, and small pipes. And what does that mean? Remember, the open pipe is obvious bleeding. So we always want to fix obvious bleeding that we see first. However, remember, if we didn't see obvious bleeding, then we were going to do blood sweeps using our gloved hands. And we were going to sweep the body, hopefully clearing those big pipe areas. And those big pipe areas are the pelvis and the legs, because that's where the big arteries are. Once we clear bleeding there, then we'll work up higher to the smaller pipes, the arms, and then the neck. Then we talked about life-threatening bleed. What is a life-threatening bleed? And I told you, remember, it was red, and it was a lot. But then we got a little bit deeper into the weeds, and we said, well, if I put pressure on it, and it's still bleeding after I put pressure on it, and so we call that dripping, that's a life-threatening bleed, and it needs to be addressed. Or if it's soaking through clothing, we can see the blood actively soaking through the clothing, that's also going to be a life-threatening bleed that needs to be addressed. And then lastly, if they're laying on the ground and that blood is pooling around them, absolutely a life-threatening bleed that needs to be fixed. And then 3, we started our conversations on stopping the bleed. We talked about pressure first and then making it better. So we've been doing pressure since day 1. So I'm still telling you, we're not changing a thing. Any obvious bleeds, we want to get pressure on that source or on the pressure point to slow or stop the bleed. So pressure first, but remember what we say after that, and then make it better. So making it better could be the application of a tourniquet or wound packing. So then we transition to bleeding from arms and legs. And then we introduced the North American Rescue CAT Generation 7 tourniquet right here. And we talked about how to put it on. We talked about high and tight, get it high on the extremity, not on the joint, and tighten that faucet down until the bleeding stops. So, a lot of good information that we passed on day 1. And if you missed it, you can certainly go back to our Facebook thread, find Bleeding Control Class Day 1, watch the video about 40 minutes, and it's going to bring you up to speed on all of those topics. So now, what are we going to cover today? Well, today we're going to pick up still on number 3. We're going to finish stopping the bleed. So we're going to talk about junctional bleeding. And that's where the arms and the legs and the head attach to the body. We're going to talk about what do we do to solve that problem. Then we're going to talk a little bit about airway maintenance. So once the bleeding is stopped, we need to at least look at their airway and make sure they're breathing as well as they can be. Then we're going to talk about shock prevention, keeping our victims warm, and then activating the 911 system. So we got a lot of stuff in store for you. We're really looking forward to it. So let's just jump right in it and get it done. All right, a junctional bleed. I've already kind of gave you a little bit of hint of what a junctional bleed is. So the first thing to remember about a junctional bleed is a bleed that's not amenable to a tourniquet, which means I can't put a tourniquet on that bleed to solve it. Let's just talk about the neck. First of all, we never ever put a tourniquet around a neck. It doesn't make sense. Or I can't get a tourniquet real high. A lot of times we call junctional bleeding high bleeding because it's so high that I can't get a tourniquet on. So when we think about junctional areas, I want you to think about necks, shoulder areas, and then the pelvis. Those are areas that we need to think about pressure first and then making it better. So how do we make it better on a junctional bleed? So we make it better on junctional bleeds by packing something into that wound channel. So there are several options that you can use. The first option we would always recommend is that you use a hemostatic gauze. A hemostatic gauze is a gauze that is impregnated with a chemical. When it mixes with your blood, it promotes clotting. It causes your body to actually start doing what it's supposed to do, clotting. And there's so many products out there in the market right now, and it could be very overwhelming. I totally get that. I've been in the business a long time, and I've tested and evaluated all the products out there. And this is where I've landed. I've landed with Combat Gauze, made by QuikClot. The manufacturer is Z-Medica. QuikClot Combat Gauze is the only hemostatic gauze that is an active hemostatic gauze. What that means is when this gauze mixes with your blood, an active process occurs. It promotes your own clotting cascade to kick in, so all your clotting factors start to work, so you get some dehydration of the vessel, and you get clots to build within that as well. So it is an active process. Some of the other gauzes on the market are what we call a passive hemostatic process. What they do is they interact with your blood. There's a chemical reaction just the same, but they form what's called a mucosal plug. And that mucosal plug, in some cases, when we violently move these patients, we can dislodge that and have more instances of rebleeding. So today we're going to be using QuikClot Combat Gauze, and we're going to be using the QuikClot Combat Gauze training gauze. Also, I'm going to show you something else. This right here is what we call a Focus Research Wound Club, and this is also a smaller version, the Wound Cube. These are excellent wound training simulators. The Wound Club, actually, you can put a red fluid in here. We have a simulated artery, so we can get down in here and we can pack this wound, and then we can get that real feel of what it takes, what type of pressure it takes to stop that bleed. So let me give you now the steps of packing a wound. The first step in packing a wound is identifying the wound. All right, what do I mean by that? So let's just use this hole right here as an example. We can get the camera to zoom down here. So if I see the blood squirting out of the wound, every time my heart beats, I see a little squirt come out. What I want to do is I've identified the wound. I know where that source of the bleed is coming from. So what I'm going to do at this point is take my finger, bring it down to the source of the bleed, and actually put my finger in that wound channel if necessary, find that pulsation of the artery, and apply digital pressure. Once I get digital pressure, now I can make it better. Man, that sounds a lot like day one. Pressure first, then make it better. Nothing's changed. So this is exactly what I've done, is I've got digital control, I've got pressure. Now I can make it better. If there's nothing that I can make it better with, I may hold pressure until 911 EMS gets there. Now let's talk about if it is not a pumping or squirting wound. Let's say maybe it's a solid venous bleed. If you remember on day one, we talked about arterial bleeds and venous bleeds. Well, a venous bleed is still a life-threatening bleed, but it may not be squirting out. It may basically, if we can focus on this laceration, it may just be filling up in that laceration, you will, and you don't see any active pumping. So how do we identify this bleed? So what we want to do is take a non-hemostatic gauze product, maybe a t-shirt or just non-hemostatic gauze, and we want to wipe that wound channel clear. When I wipe it clear, I want to look and visually see where that area is filling up again with blood. And if I see it's filling up here, then I'm going to put my finger on that area again and try to get that good digital pressure. I may not feel the pulsation in this case, but I will see the flow of the blood slow or stop. So if I was to ask you what is the first step after safety on wound packing or correcting a junctional bleed, you would say gain digital pressure or pressure first and make it better. All right, so what we're going to do now is we're going to simulate packing this wound. All right, in this situation, it's pumping. So I know that I'm going to follow my finger down to the pump, put my finger on the pump, and get digital pressure. Now I'm going to take my product, all of my product, what I like to do, there's many different ways to pack wounds. I like to take it all out. So I'll take it out, and then I'll gain access of a corner, then I'll throw the rest over my shoulder. Now this is the key point and the key takeaway, is I'm going to put the gauze on my opposing index finger, and now without ever taking pressure away, I'm going to drive this gauze into that wound channel and replace the finger. Now let me show you outside the wound cube or the wound club what I'm doing. If my finger is the artery and my knuckle is where that artery has been breached or there's a hole, I want this gauze to come in direct contact with that hole. That makes sense? I don't want to pack around it. I want to pack on top of it. And that's the key takeaway. So let's go back to the wound club here and look at it again. All right, pumping, pumping, pumping. Find the finger to the source of the bleed. Get digital pressure, hold it. Get my hemostatic gauze out. Get it on my opposing index finger and drive it into the wound channel. And now I've replaced it. Now what I'm going to do is I'm going to keep packing my gauze into this wound channel, but watch what I do. I'm going to try to fold it or Z-fold it in on top of itself. So I'm just not packing it randomly in that wound channel. And I'm going to pack as much of this as I can get in here. I'm going to pack it all the way to the bone. All the way to the bone. Once I can't get anything else in there, then I'm going to take the remaining piece of the gauze and put it on top of the wound. Now this is something I need you to remember. Once I'm in this position, using hemostatic gauze, I'm going to hold 3 minutes of pressure before I wrap it with my pressure wrap. Now, what I'm looking for during those 3 minutes is bleed through or bleed out. What do I mean by that? If it's bleeding out the side of the gauze actively, then I need to take all of that hemostatic gauze out, get a new package of hemostatic gauze, and try that packing again. I probably missed the point of the bleed. If I'm getting bleed through, I'm going to do the exact same thing. Now listen to what I'm telling you to do. I'm asking you to take the gauze out and start over again. Counterintuitive what we would normally do if we were using non-hemostatic gauze, and we'll talk about that in a minute. So once again, got my hemostatic gauze in, 3 minutes of pressure. After 3 minutes of pressure, if I don't have bleed out or bleed through, then I can start my pressure wrap. So we're going to put this on hold for a second before I go into pressure wrapping it using my pressure bandage. And I'm going to show you a couple of pressure bandages that we like. Once again, I want to be clear, this is my opinion. I've done this for quite a while. And the bandages that we like to use come from Persis Medical. This right here is the gold standard in tactical bandages. This is the Persis Medical Israeli bandage. If you ever spent any time in the military medic, you know exactly what I'm talking about. It's a multifunctional bandage. You can do so many things with it. And we are going to have a class just totally dedicated to all the different uses of this bandage later on down the line. So stay tuned for that training. But the bandage that we see a lot of times in these public access kits, the bandages that we see are not going to be to this military or law enforcement grade. They're going to be a little bit easier to use. So the bandages that you'll see a lot of times in your public access bleeding control kits are going to be the bandages that don't have the pressure bar. So if you look at the Israeli bandage, one thing that makes it very cool is it's got a pressure bandage, so we can really, or pressure bar, if you will, so we can really increase good solid pressure as we wrap it around that junctional area. When we start transitioning to some of the civilian bandages, you don't see the pressure bar, but you have to train with it to know what to do. Or sometimes seeing this device can confuse a lot of people, and that's why we see these non-pressure bar bandages in a lot of public kits. The bandage that we like, once again, is a Care 1. This is also made by Persis Medical, and so it has all the pedigree as the Israeli bandage, and so it works really well. So how do we create a pressure bandage over the wrap? So we're going to go back now and transition to wrapping the wound. So the key to this, once we get it packed, remember 3 minutes of pressure, and now we're ready to wrap, is we take the bandage. The bandage is going to have a little gauze pad or an ABD pad. We're going to put that directly over the source of the gauze. And then we're just going to wrap it around. Very user intuitive. You got away from me here a little bit. Wrap it around. I'm going to use the desk kind of to help me out here. And we're going to wrap high and then wrap low. Now if you need to increase pressure, what you can do is you can come up and watch this, put a twist in the bandage, and then continue to wrap. And you're going to wrap the entire bandage. You're going to expand the entire bandage around. And one last thing, if you're using hemostatic gauze, before you finish the wrap, I want you to take the package of that hemostatic gauze and wrap it in the wrap just like so. And then, let me get a zoom in here if I can. All pressure bandages, let me get this cord out of your way. We'll have some type of alligator clamping system. This is a very user intuitive. Basically, you just clamp it on either side of the bandage like so, and then it stays in place. The reason that we want to put the packaging of the hemostatic gauze, when the medics arrive, they know that there's been a hemostatic product deployed, and that's going to cause them to resist the urge of exposing that wound and causing a rebleed. Also, when they get to the emergency department, the doctors, the ER docs, are going to know what they're dealing with. They're also going to know they were treated by somebody that knew exactly what they were doing. So that's good stuff. So the takeaway here is when you're using hemostatic gauze, you pack it to the bone, then hold 3 minutes of pressure, and then wrap it with your pressure wrap, putting the packaging of the hemostatic gauze here so it's visible, and then you're good to go. Now let's talk about what if you don't have hemostatic gauze. I want to be honest with you. You can pack a wound with anything. So you can use non-hemostatic gauze, which would be cotton or nylon gauze. You can even use clothing or socks. So whatever you have at your disposal, if you don't have hemostatic gauze, use it. Because the whole goal is packing something into that wound channel to get up against that hole in that artery or vein and put pressure on it so the bleeding stops. Hemostatic gauze is the gold standard. It works tremendously well, and sometimes junctional bleeding can be very troublesome. So I would recommend that if you were going to build your own kit, you would tend to lean towards the hemostatic gauze. So I hope this kind of answers some of your questions there. All right, now we're going to switch gears a little bit, and we're going to talk about internal bleeding. So internal bleeding is bleeding that is in my chest or in my abdomen. Unfortunately, there's nothing that we can do as a lay provider to stop internal bleeding, other than treat for shock, and we'll talk about that when we get to that point. Internal bleeding is very much a life-threatening emergency. So there we want to maintain their airway, make sure they're breathing well. We want to treat them for shock, and we want to get them definitive care as quick as possible. We never want to pack anything into the chest cavity, and we never want to pack anything into the belly. Period, hard stop. Because our chest and our belly, we need space, we need room for our vital organs to work, our lungs to expand. By packing things into our chest cavity, into our belly, it can restrict the movement and cause breathing to be more difficult, and also our circulatory system to be more difficult as well. So the takeaway from here is internal bleeding is a true life-threatening emergency that you're going to manage their airway, and you're going to keep them as comfortable as possible and get them to definitive care and keep them warm. So that's internal bleeding. All right, so this pretty much wraps up the bleeding section of our course. So we've talked about arms and legs. Arms and legs, we're going to do pressure first and make it better. Making it better on arms and legs is going to be the application of a tourniquet. Then we talk about bleeds that aren't amenable to a tourniquet, those junctional areas, the areas for the head, arms, and legs attached to the body. We're going to use pressure first there as well, get that good digital pressure, and then we're going to make it better by packing the wound. Hemostatic gauze is always preferred. When you use hemostatic gauze, you want to pack it to the bone, hold 3 minutes of pressure, and then wrap it with a pressure wrap. Now let's talk about real quick, what if you're using something that is not hemostatic gauze? Rick, how long do I have to hold pressure for? 10 minutes. 10 minutes is the answer. 10 minutes. And also after 10 minutes, if you are experiencing bleed through or bleed out, we don't want you to remove all of the product that you put in that wound channel at that point. We just want you to add to the top of it, if that makes sense to you. So the only time we're removing the product is when it is hemostatic gauze. All right, and then lastly, internal bleeding, chest and belly, we never pack anything into those areas. We manage their airway and keep them warm, treat for shock, and get them to a medical facility as quickly as we can. All right, now we're going to segue to the fourth step in stopping the bleed, but this really has nothing to do with the bleed. It's airway assessment. So when a person is conscious and they're bleeding and they're talking to you and they're saying things like, man, this really hurts, their airway is good. So when someone's talking to you and they're alert, they're conscious, they're good. But you still need to make note of that their airway has been checked off as being good. However, when somebody is unconscious, and especially when they're laying on their back, a lot of times we're going to hear noisy respirations. When we talk about noisy respirations, we're talking about snoring or gurgling or that rattling noise. And the reason we hear that is because the tongue is actually attached to a muscle. And when they lay back, that tongue slides back and it occludes their airway. And then the snoring is that tongue vibrating as the air passes through the airway. So we have to open it up. And when we hear the gurgling respirations, a lot of times there's fluid that's built up in the back of the throat, so we have to clear that as well. So I'm going to bring Melissa and my wife real quick, and we're going to show you how to open, clear, maintain an airway. So get Melissa to come in here. Hello there again.
Hello there.
So get you to lay down on the ground if you would. And remember this, the number one airway obstruction on an unconscious or altered patient is going to be that tongue sliding back and occluding the airway. So notice her chin right here. The way she's set up here, she's set up in a perfect position to cause her airway to be compromised. So if you've ever been through a CPR class, they've taught you how to open an airway, and we're going to do the exact same thing here. So the first thing we're going to do is the head tilt chin lift method to open it and take a quick peek. So all we're going to do is tilt her head back, get that chin straight up to the ceiling, and open her mouth and take a look. And also, by doing this, we're stretching that tongue, getting that tongue to come forward, where now it's no longer occluding the airway. So the snoring should actually stop. So if I was to ask her to try to snore, it'd be very difficult for her to snore. Try to snore. She's trying to snore, but it sounds more like a wheeze because that tongue is just stretched forward. All right, so that's the opening piece. But now, what if she's gurgling? What if there's fluid in her airway? So now we have to clear it. When we clear an airway, we want to let gravity work in our favor. So how do we do that? So what I want to do is I want to roll her. It's always easier to roll someone towards you than away from you. So I'm just, for training purposes, get her to slide over, please. Get her to slide over. And I'm going to put her arm above her head. I'm going to roll her leg this way. And I'm going to roll her towards me. And by rolling her towards me, now her airway is down. Any fluid or blood or any other substance in her airway will leak out and go on the floor. So this is clearing. But now say she's going to be here for a period of time. Now we have to maintain. So how do we maintain an airway? Well, I'm going to give you, for training purposes, I'm going to roll her on the other side and show you how to put someone into a recovery position or a maintenance position. Now, before we do this, I want you to be very conscious of something. We're going to lay her or your victim on the side based on whether or not they have a chest injury and where that chest injury is located. And then later on in the presentation, I'm going to give you exactly why. We're going to get deeper in the weeds on that. So if she has, let's assume, a chest injury on her left side, and she is unconscious, and I need to maintain her airway, I'm going to lay her on her left side. So remember this, injury side is always down, or keep the bad side down. So let's put her in that maintenance recovery position. So what I'll do is I'll take her arm, put it over her head, then I'll roll her on her side. And this is really important to note. Any portion of the body that comes in contact with the ground will be straight. Any portion that's not in contact with the body will be bent. Come here bent as well, and then bring her head down like so. So by gravity, by virtue of gravity, anything that builds up in the back of her throat will drain out, and also gravity will keep her tongue forward. So this is the recovery position we want to be in. And just to review, if she's conscious and talking, then this is not necessary. We only need to open, clear, and maintain an airway if somebody's altered or unconscious. All right, thank you, Melissa. Let me help you out. Perfect. So you've heard me say a few terms through the course of this airway module. And you've heard me say open, clear, maintain, and supplement. Because that's exactly what you need to do to open an airway. So think about this. Open, head tilt, chin lift, take a look, fix anything you see, clear, roll them on their side, get rid of the fluid, get rid of any foreign objects, maintain if they're altered in that recovery position based on their injury, chest injury, and then supplementation. Let's talk about that for a minute. If they are breathing poorly, they have poor rise and fall of the chest, or not breathing at all, you want to breathe for them about one breath every 5 seconds using some type of rescue mask, and then just follow the instructions of those rescue masks. All right, so airway, open it, clear it, maintain it, supplement it. Now let's go back and talk about the chest injury real quick. So we talked about if we had a penetrating chest trauma, what do we need to do about that? And we want to lay them on their affected side. Well, we want to prevent a condition called a tension pneumothorax. So if this mannequin is representative of an injury in my chest, penetrating chest trauma, we want to make sure that air can't leak into our chest cavity, and that air would be outside of our lung and then cause our lungs to collapse. So what we want to do is we want to create an airtight seal. An airtight seal. Most of your bleeding kits, your public access bleeding kits, are going to come with some type of vented chest seal. This is the Hyphen vented chest seal. It comes from a North American Rescue. Once again, my opinion, absolutely by far the best vented chest seal on the market. What it is, open, is just basically a piece of plastic with a vent in the middle and some adhesive on one side. What this does is we can stick this over both the entry and the exit wound, and that will stop air from leaking into our chest cavity and stopping that air from going into what we call the pleural space, and that's the space in our chest outside our lung. We get too much air in our chest, in our open chest space outside of our lung, it's going to cause our lungs to collapse. Remember, we want to stop all bad air from getting in there. So all we're going to do is you can put on a Band-Aid, you can put on a chest seal. You just peel it off like so. Sticky side goes over the wound, and the vent itself goes over the wound, just like that. Most standard public access bleeding control kits will come with some type of chest seal. However, if you don't have access to a chest seal, you can use any type of plastic. You can use cellophane wrap. You can use your hands, just something to stop the air from leaking in. And that is what we want to do when we have some type of penetrating chest trauma. And also, we want to lay them, remember, on that affected side, keeping the bad side down, because if there's any blood building up in that chest, I need it to leak out of the chest. And these vents will allow the blood to leak out. Remember, we can't do anything to stop the bleeding, and I don't want you bleeding in your chest. But if you have to be bleeding in your chest, I'd rather you bleed out of your chest than the blood staying in. These are called vented chest seals. Hyphen vented chest seals, in my opinion, once again, are the best chest seals currently on the market. And then lastly, we're going to talk a little bit about treatment of shock. Treatment of shock, once we've stopped all the bleeding, we have a good airway, we have all the holes patched up in the chest, we want to keep our victims warm, and let's talk about that. So there's a couple of things in our blood that cause us to create heat. Normal body temperature, core temperature is 98.6. When we get to about 95 degrees, we start to become hypothermic. The first thing to remember about hypothermia is cold blood does not clot. So if we have any internal bleeding and we let them get hypothermic, they're going to bleed even faster. All right, and also something else to think about, the two things in our blood that we metabolize or burn as fuel to create heat is oxygen and glucose. So if all of our glucose, all of our sugar in the form of blood is laying on the ground and not in our body, then we can't burn those molecules to create heat. So our body goes to plan 2, and it starts to burn fat. When our body burns fat instead of glucose to try to metabolize heat, what it does is it creates a horrible byproduct of acids. Those acids get into our internal organs and it shuts us down and it puts us in shock. So the key to this is you keep your victims warm, not based on the temperature outside. It can be 100+ degrees, and we learned that downrange in the desert where people bled out a lot. We didn't keep them warm and they had hypothermia issues. So you have to keep them warm based on the amount of blood they lost. So what is a good judge, if you will, on should I use some type of Mylar warming blanket or use some external clothing to keep them warm, maybe remove them off the cold ground and put a barrier underneath them? What's a good judge if I need to do that? Well, first of all, if they're conscious and talking and thinking clearly, they're not altered, and they didn't lose a lot of blood, then I think you're safe just to monitor them. If their condition worsens, then we may have to pull a few more levers, and one of those levers may be heat. But if you get there and they've lost a lot of blood, and they have bad color, maybe they're pale, maybe they have that cold sweat, maybe a little bit of blue tinge to their lips or in their eyes, or maybe they're just a little confused. Those are situations absolutely where we want to give that external heat. And what we're trying to do is keep them as warm as possible externally so our body doesn't pull that lever and starting to burn fat. Because once it starts to burn fat, remember that byproduct of the acids, and we really want to kind of fool our body. Does that make sense to you? I hope so. So the number 5 is the treatment of shock. Keep them warm. Mylar blankets work great, and in most cases, you're going to see a Mylar blanket in most of your public access bleeding control kits. All right, and last 6, seeking medical attention. So you would think it'd be pretty intuitive to pick up the phone and call 911 and get medical care. And that's what I need you to do. But this is what I'm going to tell you, and listen closely. I need you to go through all of your steps of hemorrhage control if you're by yourself before you ever get on the phone. It's more important that you stop the bleeding. It's more important that you put tourniquets on and pack wounds and stop the bleeding before you get on the phone with 911 and report the injury. Once you've done that successfully, then you've bought yourself a little time to get on the phone and activate the 911 system. That's if you're alone. If you're with somebody else, then direct them to call 911 while you're still working at stopping the bleeding. Does that make sense? And remember all the information you got to give. Where are you? Easiest access. And you're going to set up a link up to meet EMS when they get here. But it's very important that the bleeding control is done first. Remember, you're the immediate responder. You're the first person that's going to lay hands on that individual, and it's very important that you do so. So under 6, seeking medical attention is very important. So in summary, we want to talk about the 6 steps again. And this is kind of bringing both days together. The first thing we have to do is ensure our safety. Make sure it's safe enough that you don't get injured, right? Make sure it's safe enough to perform these hemorrhagic interventions, stopping the bleed. Then once it's safe, we're going to locate and identify the injury. We're going to find it and then identify it, is it life-threatening or not? Then we're going to stop the bleed. We're going to stop the bleed by putting pressure first, and then we're going to make it better. Arms and legs, you're going to get tourniquets high and tight. This is on an arm or a leg. Hopefully we have some hemostatic gauze, some quick clot, and we're going to pack it into that wound channel, and we're going to put a good pressure bandage on it, and that's going to solve that problem. Internal bleeding, we're going to treat for shock, and we're going to get them to help as fast as we can. Then, after we stop the bleeding, we're going to make sure we have a good open airway. If they're talking to us and they're alert and conscious, that's a good deal. They've got a good airway. However, if they're altered, not talking to us, unconscious or confused, then we're going to open, clear, maintain supplement using the head tilt chin lift to get rid of the snoring, and then roll them on their side to get rid of the gurgling, and then leave them on their side if they're altered based on any injury on the chest, laying them down with the injured side down. And then we're going to keep them warm. We're going to treat them for shock. And how do we know if we need to keep them warm? Add that external heat? Well, we're going to look at it. When I went through my first medic course, my instructors used to say, man, if your patient looks sick, they're probably sick. I don't care about those machines. Look at your patient. And I'm going to tell you to do the same thing. Look at your patient. Look at your family member. If they look sick, then they are sick, and treat them accordingly. So if they're pale, if they're cold, if they're diaphoretic, that cold sweat, if they're confused, then we absolutely have to keep them warm using that external mylar blanket, using something like this or external clothing. Get them off the ground because the ground will suck a lot of heat out of you. So just make sure we keep them as warm as possible. And then lastly, make sure that we've activated the 911 system. Whether we had someone there with you and they're doing it simultaneously, which is the best case scenario, but if you're by yourself, I need you to stop the bleed first, then activate the 911 system. Those, my friends, are the 6 principal steps in Stop the Bleed. We know they work. Every class we've done, within 30 days, we'll get an email and someone says, I've had to use these to save a life. So this is what your challenge is to you today, is I want you to go back and watch day 1 again, and I want you to watch day 2 again. I want you to mentally prepare yourself to make sure that you're able to do these tasks under great stress and pressure. You need to be prepared now for your emergency tomorrow. We don't want to learn new things under stress, right? We want to learn them now and be proficient. This is a skill that you should already have wired into your brain before you need it. So watch the video 1, 2, 3 times, share it with your friends, and make sure that you're competent and confident. Also, I challenge you to go out and seek some bleeding control kits. So if you remember on day 1, when I was talking about public access bleeding control kits, and I backed away from my desk and I was looking for this guy right here. I wanted to give you a kind of a demonstration of what a public access bleeding control kit looks like. So make sure that you have access to these, whether they be in your vehicle, in your home, in your sporting bags, if you're a camper, in your backpacks. These save lives. It's better to have it and not need it than to need it and not have it. All right, so let's just go ahead and close this day out. So So you remember on day 1, I told you about the 100 Club. The 100 Club of San Antonio and the 100 Club of Como County. So again, we are so very honored to have partnered with both of these nonprofit organizations, the acquisition and distribution of tens of thousands of dollars of personal protective equipment to help support the COVID-19 response. And I'm so honored that we have the opportunity to work with these guys. I'm going to take you back in our warehouse right now and kind of show you some of the stuff through their generous donations that we've been able to provide to first responders across our region. So if you come over here, from everything from disinfectant wipes to Clorox to face shields to the N95 masks to surgical masks to gloves to hundreds and hundreds and hundreds of gallons of hand sanitizer. This has just been such a blessing to be able to help support them, supporting our first responders. So this is what I'd ask you. If you'd like to support this cause, that would be awesome. You can go to our pin post, find their link in our pin post, hit their link, and then it'll take you to their Facebook page. On the left nav bar, you'll find a donate button. If you feel like it, smash that donate button, throw them a few dollars your way, and help them support the efforts as they support your first responders. If you're not in the Alamo area, that's cool. Find an agency in your area that you can use to help support our first responders. They're out there supporting you. The least we can do is support them. So in closing, once again, thank you so much for letting me come into your spaces today, letting me talk to you about Stop the Bleed. And as always, please stay healthy, stay safe, and have a great night. Thank you very much for your time.